Many thanks for giving me the opportunity to present today at ICS Virtual Meeting 2021. I'm Naser, Senior Clinical Fellow with the Reconstructive Female and Functional Team at University College Hospital, London. I'm presenting today our study, Female Stricture Characterization. I have no interest to declare. Female bladder outlet obstruction is a relatively uncommon cause of lower tract symptoms. It accounts for 2.7 to 8% of women with LUTs. A small percentage of those women will have female urethral stricture. Given the rare occurrence of the problem, there is no consensus on the diagnosis of female urethral stricture. The aim of our study was to assess the history, imaging, and urodynamic characteristics of all women seeking urethroplasty for recurrent symptomatic female urethral stricture. A retrospective review of prospectively acquired database of 55 women who underwent urethroplasty at our center were assessed for stricture etiology, presenting symptom, previous stricture treatment, MRI, and video urodynamic findings. The etiology was unknown in the majority of the study population. The women had multiple previous urethral dilatations with a mean of 6.7 times. 58% were performing intermittent self-catheterization. All of them found it painful, and 2 out of 55 women had an SPC in situ because of pain performing self-catheterization. The median duration of symptoms was 60 months. The most common presenting symptom was poor flow in 98% of women. Other symptoms were frequency nocturia, urgency, urethral pain, and recurrent UTI occurred between 70 to 80%. In our center, we perform MRI pelvis, video urodynamics, and cystourethroplasty under GA for women with suspected urethral stricture. MRI revealed a concentrically thickened urethra in 64%, missed the diagnosis in 24%. However, it has the advantage of revealing or diagnosing associated pathology as urethral diverticulum and raising suspicion of other pathologies as urethral cancer. Video urodynamics showed bladder outlet obstruction in 100% of the study population. The Truser overactivity was found in 38% and stress urinary incontinence in 13% of women with female urethral stricture. On the right hand side, we can see a video urodynamic fluoroscopy image with ballooning of the urethra and CMG showing high pressure, low flow voiding characteristic of outflow obstruction. In conclusion, female urethral stricture should be suspected in all women with poor flow and irritative lower urinary tract symptoms. Urodynamic bladder outflow obstruction is present in almost all women with female urethral stricture. Urethroplasty should be considered earlier, and delay caused by overuse of endoscopic management should be avoided. Thank you.